All right. Good morning, everyone. We're right at 10 o'clock this morning, Central Time. So we're about ready to get started with our webinar today. I just want to thank everyone for joining us. We're so happy you're here. Our core slides we have pinned, we put them in the chat. I will put those again in the chat again. The link to those one more time before the start of the presentation, and the link in there should download those slides automatically in a PDF format. If you have any questions during the presentation, please put them in the Q&A or the chat function. We will monitor both of those and have time for questions at the end. To obtain your CEU credit for this course for attending, you must complete the survey at the end of the webinar. That survey should automatically populate in your browser after you exit the webinar. If it doesn't automatically populate for you, don't worry. There should be a link coming to you in a follow-up email you will receive as an attendee 24 hours after the completion of this webinar. And then you'll be able to access the survey that way. Once you complete the survey, your response has to be verified by our education team. A certificate will be emailed to the email address you used to register for this webinar. Just please keep in mind that that might take a few days as we do that all manually. But with that, like I said, please put your questions in the chat and the Q&A and we'll monitor those. And thank you again for joining us, everyone. I hope you enjoy the webinar. I will turn it over to Kristen.
Awesome. Well, thank you guys all so much for joining us today. Our topic that we're going to discuss is thinking beyond the wheelchair after spinal cord injury. We're going to get into utilizing, fitting, and funding supported standing devices. So just a real quick background on myself. My name is Kristen Czat, and I am a physical therapist by background. And I have spent the last 13 years of my career treating clinically in a more acute setting, an inpatient rehab setting, emphasizing individuals with spinal cord injury, although I have treated adults across really all neurologic populations, but spinal cord injury has been my area of passion and expertise throughout my career. I've been afforded the opportunity to really be involved in a lot of different aspects of spinal cord injury practice, from clinical care to the community side of things, and advocacy, and all different roles in that kind of continuum of spinal cord injury rehabilitation. Today, I'm going to be talking to you in my new role with Ultimate Medical. I am the clinical education specialist, one of two, with Ultimate Medical. So today, I just real quick disclosure, I am presenting as a full-time clinical education specialist for Ultimate Medical. And while we will be discussing different technology related to supported standing devices, as with any CEU, we won't be going into product specific. So if you do have questions on Easy Stand, which is the product that Ultimate Medical manufactures, at the end of the presentation, we'll kind of take the CEU hat off, and anybody from the Ultimate Medical team, we're happy to answer those questions for you. All right, so we're going to look at the objectives for today's discussion. So we're going to first start with, we're going to provide 2 evidence-based reasons to use a supported standing device following a spinal cord injury. We're going to look at identifying 2 necessary assessments to properly fit a client for a supported standing device, and we'll talk about that kind of in multiple settings. And then we're going to look at some of the necessary components. We'll specifically look at 3, but many necessary components of the letter of medical necessity, that dreaded letter of medical necessity, that can be used to help us to fund supported standing devices following spinal cord injury. All right, so as we get into this discussion, again, there are many different types of supported standing devices out there. Everything we're going to discuss today is going to be relevant to spinal cord injury, and kind of the industry and how is this technology being utilized in clinic as well as in home use. So let's kind of get into a little bit of background about spinal cord injury in general. So for those of you who practice an SCI regularly, this is not new, but we have multiple different types of injury classifications that we discuss following an SCI. So the first one we're going to talk about is tetraplegia. So that is when somebody has an injury to the cervical spine and we have all 4 limbs affected following injury. So tetraplegia, also interchangeable as quadriplegia. Both of those terms mean the same thing. When we get into paraplegia, we're looking at the thoracic, lumbar, and sacral injuries. So we're looking at trunk and leg involvement in that type of presentation following an SCI. The next classification that's really important to understand for the client in front of you is, does that individual have a complete spinal cord injury, meaning we don't have any motor or sensory preservation below where that injury occurred? Or do we have an incomplete spinal cord injury in which there's damage to the spinal cord, but we have some level of either sensation or motor that is getting past where that level of damage is? And an individual with an incomplete spinal cord injury can really look like a lot of different things. So there are no two individuals with incomplete SCIs that look the same. When we get into the incidence of SCI, I just updated these with the 2024 National Spinal Cord Injury Statistics Center. And again, we're looking at traumatic spinal cord injury demographics here, but about 67% of all injuries are incomplete, where we have that kind of 32% being more of the complete, that traditional like paralysis that we may think of after a spinal cord injury. And I will say, in the world of complex rehab technology, which is what we're going to be discussing with our supported standing devices, I think our minds are always drawn right to the 32% of the complete spinal cord injuries and what their CRT needs may be very early after injury, because it's much more obvious. It's very apparent when that individual is unable to walk, that we need a wheelchair, we need a commode, we need a supported standing device as things to consider for that individual. But that 67% of incomplete spinal cord injuries can be much trickier because the presentations vary so widely. So early after injury, I would say in clinical practice, I see that 67%. Sometimes the CRT needs go undetected or unrecognized for longer periods of time before intervention is initiated from a complex rehab technology perspective. When we look at the percentages of types of injuries, our highest population is individuals with incomplete tetraplegia. So again, if you are in SCI care regularly, we know that after a spinal cord injury, it is not just the strength and sensation that is affected. There is really almost every system of the body has some sort of impact from the spinal cord injury. So we have the things we think of traditionally, paralysis or paresis, depending on how severe the impairments are, that altered or absent sensation, but also considering the bowel, bladder, and sexual dysfunction that will occur following a spinal cord injury, and how interfering that can be in an individual's lifestyle, especially in the beginning when someone's learning how to manage those areas, but even long term. Looking at respiratory dysfunction. And we often think in spinal cord injury of respiratory dysfunction as our higher levels of injury, right? If you think back to school, C3, 4, 5 keeps us alive because that is what innervates the diaphragm, which is one of our major muscle for breathing. So individuals who have those injuries at C3 and above, we're usually looking at some kind of ventilator dependent needs for being able to breathe. But as we get into the C4, 5, 6 range is when we really start looking at being able to breathe on our own. But any individual with a thoracic injury and above is going to have some kind of effects to the respiratory system from the fact that if we have weakness or paralysis through those trunk muscles, which help to expand our trunk musculature, then we're going to see some impairments even in some of the lower individuals that we may not think about. Autonomic dysfunction will be present in individuals who are a level T6 and above. So autonomic dysfunction really comes of where that injury occurs in the spinal cord in the T6 and above range. You have two systems of the nervous system that aren't communicating anymore. So you have the parasympathetic and the sympathetic system who aren't able to communicate the way they did prior to injury because of where that damage is. So we see things like neurogenic orthostatic hypotension, where we can't regulate our blood pressure appropriately. We see autonomic dysreflexia, again, which is an imbalance in those two systems, where we see hypertensive blood pressures, thermoregulation and temperature control issues. But again, we're looking at those higher level of injuries based on where the anatomy is in our body. And then lastly, talking about spasticity. And spasticity is a very tricky aspect of any neurologic injury, but especially in spinal cord injury because it changes and evolves so greatly, especially over that first year after injury. So we see initially when somebody has a spinal cord injury, they go into spinal shock, in which the whole body goes hyporeflexive, meaning, weakness and paralysis. But as that spinal shock period evolves, the individual will start to see, if they have an upper motor neuron injury, they'll start to see the evolution of spasticity come, and it changes over those first few months and even years after injury. So it's something that's difficult to dial in from a complex rehab technology perspective because it is a moving process in the earlier days after an injury when we are prescribing CRT to that individual. Now, we talked about all the different physiological kind of systems that are affected, but looking at the complications that then individuals with spinal cord injury are at risk for. So, respiratory complications, again, looking at usually the higher levels, but again, we talked the thoracic and above can be at risk for respiratory infections or pneumonias because of the paralysis of those muscles. Looking at pressure injuries, and we know that individuals who are unable to feel or move and maybe having continence present, we are not moving around the way that we did prior to our injury. There are many different factors that play into pressure injuries, but it is very commonly discussed in the literature because of the high risks that come and the implications that we see as a result of that. Urinary dysfunction and UTIs, individuals with spinal cord injury have risks for UTIs depending on the type of urinary program they're on, whether that's an intermittent catheter program or a suprapubic or an indwelling catheter or maybe a spontaneous voiding program. But UTIs, again, are commonly cited in the literature, and we see it in clinical practice as well. When we get into things like the GI system and we have the slowed motility because of the spinal cord injury, so we're at risk for things like constipation or impaction after our spinal cord injury. And so when we look at the most common reasons that individuals are rehospitalized after their injury, especially in that first year, the same thing that we looked at from that National Spinal Cord Injury Statistics Center, they discuss some of the top reasons being urinary complications and UTIs, integumentary skin issues or pressure injuries often seen, and then looking at GI and respiratory complications kind of hand in hand as the top reasons that we see individuals back in the hospital that first year after they're discharged from inpatient rehab. So those are things to kind of think and keep in mind with the interventions that we are applying. When we get into osteoporosis, and we'll look at this when we talk about the supported standing evidence, bone health and bone mineral density is going to be affected in individuals who are immobile from a standing perspective. If we are non-ambulatory, we anticipate that there is going to be some level of bone mineral density loss in those, we'll talk about the timeframes, but the first few months and years after injury. Pain is also commonly reported as a complication that can be very, very interfering and detrimental to an individual's life. The cardiovascular comorbidities that come after spinal cord injury, and we really have two different categories. We've got modifiable risk factors, which are things like, we're not moving very much, so we're sedentary. We have things like after we have paralysis of our muscles, we start to get breakdown of the muscles themselves as they atrophy, and we see higher levels of things like cholesterol and lipids in the body that we would not see otherwise. So those are things that are kind of modifiable risk factors versus the non-modifiable. We can't control the individual's age or their family history, but all of those things come together to put that individual at a higher risk factor for cardiovascular complications long term, because individuals are living so much longer with SCI, which is a great thing, but we're seeing more cardiovascular comorbidities arising. And then lastly, the joint contractures that will occur if somebody is not moving out of positions and they're staying in those positions for prolonged periods. So we often see this in the seated position and also in individuals who maybe aren't getting up out of bed very often in that kind of supine position. So it can happen in multiple different ways if we aren't mobile and active throughout the day. All right, so let's look at some of the supported standing devices and the technology that's available, and why do we use supported standing after a spinal cord injury? So we kind of think of one of the first things in acute spinal cord injury care that you see in almost every hospital or clinic across the country is a tilt table. And it's a easy way to get somebody up on their feet for the first times where you don't have a lot of fitting that you have to do. You can monitor all of the things that you need to from a vital capacity, from blood pressure, things like that. So you see those in clinic often, not really a home device. I don't see tilt tables prescribed. So when we start looking at clinic versus personal use is when we start to look at some of the different technology available, such as standing frames, which are a separate device that the individual will transfer into, and then integrated standing into the wheelchair system itself. In some of the literature, it even discusses like long leg braces as considered as a supported standing option, but different evidence kind of classifies that differently. All right, so as we dig into the evidence here, I always like to start any evidence-based conversation with, if you are a clinician in clinical practice, when you went to school, whether you're a PT, a OT, doesn't matter, physician, nurse, recreational therapist, doesn't matter what your role is, we are really, integrated in our mind with this concept of evidence-based practice. And so it's so important to understand that evidence-based practice is based off of three different kind of pillars that are really important. One of those is the current literature for whatever topic it is that you are discussing or looking into. So the literature is one of those pillars, the evidence. The clinical expertise and experience of the healthcare professional or the team, as well as the end user or the individual living with, in this case, spinal cord injury, their perspectives and their goals. And if you don't address all three of those aspects, you're really, from a clinical intervention standpoint and decision-making standpoint, we're missing the boat. So while we talk about the evidence here, we're really going to think of all of that combined. So the evidence mixed with our clinical experiences, as well as what individuals with spinal cord injury are reporting when discussing things about supported standing. So there's a whole plethora of discussions in the evidence right now. And when we look at the different evidence-based kind of reasons for standing after spinal cord injury, we think of activity and participation in opportunities, bone mineral density effects, range of motion and stretching out of that kind of seated position, spasticity management, respiratory health, bowel and bladder health, pressure relief opportunities, as well as the psychological benefits of being up on our feet again. I always kind of remind people when we talk about any complex rehab technology that while we learn some of the evidence, we are individually assessing each person in front of us of what are their goals for the supported standing program that we are going to embark on. And so it may be all of these things, or it may be very specific things that we are targeting based on that individual's needs. All right, so we're going to dig into some of these studies. And in CRT and complex rehab technology, especially supported standing, there's many aspects to evidence, from very high level meta-analysis, high level evidence, all the way down to things like a case study where we're looking at one person's experience with whatever the individual studying. And in complex rehab technology, it is an area that there is a lot of evidence, but not as many like randomized controlled trials and things like that, because it's difficult in complex rehab technology to do that type of research, because we can't really withhold interventions that are necessary to somebody's function. So some of the things we're going to look at here are going to be more like observational studies or survey studies, which I really, really value when it comes to complex rehab technology and supported standing. Getting the perspective of the end user when we're considering the technology that we're prescribing is essential when looking at the evidence. So for activity and participation, there's two major surveys that were done in spinal cord injury related to supported standing from Ng et al. And Dunn et al. And both of those surveys, individuals with spinal cord injury were reporting increased ability to perform ADLs. And there's so many other ways to be active and participate in different things such as ADLs, IADLs, different leisure activities, social activities, and being eye to eye with our peers. Supported standing devices can be used as a tool to facilitate exercise and strengthening and balance. There's so many different things that can be done that involve increasing that individual's access and opportunity to participating in whatever the goal is that we're just discussing here. So again, the surveys kind of support that in individuals who have spinal cord injury. Now, when we look at bone mineral density, the evidence is really kind of widely varied on some of the different recommendations and what this looks like. And I will say, as a practicing clinician, this is a topic that I had a few aha moments kind of throughout my career in how I thought about bone mineral density loss. So, one thing that's really important to note, because myself early in my career, I kind of thought of osteoporosis and bone loss as I always worked on the early intervention side. I thought of that as like an outpatient problem. This is something that's going to happen later down the road, many, many years. And really, that's not when I got to where I dug into the literature and I had more clinical experiences, that is not necessarily the case. Edwards et al. And Frey Rendova et al. In their studies, they found that bone loss in the lower extremity trabecular bones can be as high as 40% in the first 6 months after injury. So we are not talking years later, we are talking weeks and months after injury that bone loss is starting to occur. Now, the evidence also discusses that those who start a supported standing program early, continue it long term, and stand in higher doses have the greatest effect for bone mineral density. So, again, we as clinicians have to think about how are we dosing what we are trying to do in any intervention, but especially in supported standing. If this is something that we're doing 3 or 4 times in clinic, and then the individual never does it again, we're not really targeting in on the benefits that we maybe are trying to achieve, such as bone mineral density. And we'll look at that in the next slide a little bit more detailed. So again, thinking about how the intervention is being used. And then Alekna et al. Found that those who stood 1 hour per day, 5 days a week, which we'll look in a second, had a significantly higher bone mineral density at 2 years post-injury than those who did not stand in those frequencies. So in the literature, there is not a standard agreement on how long somebody has to stand and how many days a week to affect bone mineral density. So different studies will say different timeframes. Some people look at an hour, some people look at longer. So as you assess each individual article, kind of keeping in our mind what the literature says and how is that clinically or personally able to happen in that individual's world. Now, when we look at in spinal cord injury, there are clinical practice guidelines that are available through the Spinal Cord Injury Consortium. And these are really a great gold standard tool available to healthcare professionals of all disciplines on major topics related to SCI and the best available evidence and guiding practice that is done at the time of that review. So in these guidelines, there's every topic. There is acute management, bladder management, bowel management, there is a CPG on a variety of different topics. And one of those is bone health and osteoporosis management. So this came out in 2022, and they looked at all different interventions, medically and clinically from a therapy perspective. But what the guidelines mentioned for supported standing is that we may consider passive standing 1 hour, 5 times a week for at least 2 years to reduce bone mineral density decline at the hip and knee. So again, we are looking at ways of how, as clinicians, can we help our clients to access technology to maintain this for the long term, not just in clinic where we do it as an intervention and then it never happens again based on what that literature tells us. They also discuss that kind of the combination of supported standing as well as muscle activation. So individuals maybe who have incomplete injuries who can still have some motor preservation, and maybe individuals who don't have any motor dual interventions to use in clinic, maybe like supported standing and FES application, but they discuss that a minimum duration of 1 year of muscle activated and lower extremity load bearing rehab is needed before we start to see that effect on bone mineral density. So again, how are we using this intervention from a dosing perspective? And then when we get into the more chronic injuries, because a lot of the literature discusses that preventative, the early intervention, that right now there isn't robust information discussing that individuals who already have severe or chronic onset osteoporosis, that there's really anything we can do clinically to change that. However, that there aren't really adverse effects. They talk about how there's no adverse effects reported associated with the things that they looked at for starting a passive standing program in that population. Meaning there are many different benefits to why we want to stand somebody. So sometimes folks will come in chronically who haven't stood in many, many years, in which case we do need to consider what is that individual's risk factors for the osteoporosis that may already be present, in talking with the physicians that you are, in your practice, or whoever's overseeing this person's plan of care, to be able to weigh out the risks and benefits, to make sure that starting that supported standing, we don't need to do like further testing. There isn't anything in the literature to say a time frame that, if the person hasn't stood in this long, then we need to XYZ. That doesn't really exist. So it is looking at each individual person, but that it's relatively safe starting a passive standing program if we consider the whole picture and talk with our physician partners. So important to consider. When we get into range of motion and stretching, there has been, you kind of think of it out loud. It's not rocket science. If people are sitting often and we get out of that sitting position, we're hoping that we're going to see benefits, right, from a range of motion perspective. And that is what the studies show. So this happens to be from a systematic review that looked at upper motor neuron injury individuals in general. So this particular one is in MS, but they found statistical significant improvement of the ankle and hip range of motion versus a standard control exercise group, for individuals who did a supported standing program. There are also survey studies where individuals talk about that they find that they have the improved ability to straighten their legs when they are participating in a supported standing program versus individuals who are not doing that. So it's a really, really nice way to be able to, we as clinicians give lots of different tools to individuals. We say you can stretch in your bed, you can get on your stomach and stretch. A supported standing program is an excellent tool to be able to give them another opportunity to find ways that they can stretch and change position for their body and do it for prolonged periods of time. So that part is really important, of how long somebody can sustain a standing position to stretch that, all those muscles out, versus, very brief, quick stretches that they may do in their bed. All right, when we get into spasticity, spasticity is really interesting because there aren't great definitions of what spasticity is. So spasticity, I Dr. Phil Fote out of Shepherd Center, she and her group did a very, very large survey study of over 1,000 individuals that came out in 2021. And the title of this study was Characterizing Experiences of Spasticity Following SCI. So they asked a ton of different questions to individuals about their experiences of living with spasticity. And I will say, in clinic, we often think of, we learn in school that it is velocity dependent movement that over exaggerates the muscle. But that is not what individuals with, we don't see that in clinic all the time. And that is not the only way that spasticity presents itself. And the study showed that more individuals reported stiffness than they did spasms in that traditional way. While those are still present for many individuals, stiffness was one of the top complaints for the effects of spasticity. But what this study showed that I thought was really meaningful for PTs and OTs is that individuals, again, over 1,000 individuals in this study, more people reported that stretching and exercise were being used to manage their spasticity at home than antispasmodics. So that doesn't mean we're telling people don't take medicine. That's not the case. But individuals find that stretching and exercise has a big impact on their spasticity management at home. And for individuals who are unable to stand, a supported standing device can be a great tool for that prolonged stretching and exercise that can occur, so that that individual has another way to manage spasticity. I married into a family that my father-in-law has an incomplete spinal cord injury. And so on a personal level, because in clinic, I only see, I see people 60 minutes, 90 minutes throughout my career. I don't see them all day long throughout their lifetime. But my father-in-law, I have traveled with him. I mean, we spend a lot of time. He's a wonderful friend to me. So to see what his spasticity looks like and that stiffness that occurs from not changing positions, it's really tough when an individual is sitting in a prolonged static position to not have the access to change positions to help manage that. When we get into the respiratory discussion, we think of that kind of posture. Individuals with spinal cord injury get into that C posture, and that Lynn et al. Shows that that really reduces the lung capacity and expiratory flow volume. So when we get into that upright standing posture, we are able to open up the lungs to help with some of the breathing difficulties that individuals may have. And then as far as bowel and bladder, again, the survey studies show that individuals who are on standing programs report benefits to their bowel and bladder programs versus individuals who do not stand. Johns et al. Is one of those clinical practice guidelines we discussed for bowel management. And they say in that CPG that a standing program may be beneficial for bowel management in individuals who do not stand or walk on a regular basis. So something to consider. And then while there are studies that have tried to objectify the outcome, so it's hard to find outcome measures for bowel management from a quantifiable perspective, but Kwok et al. In 2015, they use outcomes to try to determine if a standing program was effective on those bowel outcome measures they looked at. And while they didn't find statistically significant meaning, the individuals, almost half of the individuals in that study, 8 out of 17, reported that they thought their bowel function had improved by participating in that standing program. So again, looking at that end user's perspective is very important. Pressure redistribution is another aspect that is a benefit that we use supported standing for, because we're getting the pressures off of our bottom. So again, thinking about anytime we can spend prolonged, we teach people their pressure relief techniques to tilt, recline, prone positions when they're not in their wheelchair. Supported standing is another tool that we can offer to someone to be able to pressure relief through some of those most at-risk areas, such as, the posterior pelvis, the ischial tuberosities, the sacrum. Sprague et al. Did a very, very small study, but they found their results were that individuals should include tilt, recline, and standing systems as a consideration for weight shifting for wheelchair users. And there are individuals who maybe perceive standing as a more socially acceptable way. So maybe we see a little bit more improved compliance with a pressure relief program when standing is mixed into that ability to perform pressure relief. And then lastly, looking at the psychological benefits. So in clinic, I've worked with thousands of people with spinal cord injury over the years. And when I first meet them and ask them what are their goals, I mean, I can count on maybe two hands how many people don't say some form of I'd like to walk again and stand and return to the way that I was moving before. So from a psychological benefit, the survey studies that have been done do show individuals report improved well-being and quality of life through the different measures that they look at when individuals are on a supported standing program. And again, researchers are always trying to identify how long does this need to happen? How many days a week does this need to happen? And it does vary in the different studies that are out there. But Ng et al., for example, looked at individuals who stood 40 minutes 4 times a week, reporting a vast majority, 87% of those individuals reported benefits of well-being with their standing program. So just many things to consider. So as we tie that all together and we look at the clinical considerations, we are thinking about from a PT/OT clinician perspective, when are we starting this intervention? Are we starting it very early and thinking of that proactive approach? Or was there maybe many barriers that early intervention couldn't occur and we're starting this at a later period? But knowing that depending on what the goals are for the supported standing program, that the literature supports for bone mineral density, the earlier we can start that, the better impact we may have. And then looking at from a dosing perspective, it varies widely in the literature. So anywhere from 3 to 7 times a week. And again, it depends on the specific goal that individual is looking for. So if it's bone mineral density, we want more frequent standing. And if it's things like maybe pain or range of motion, many studies have been done in that kind of 3 to 4 times a week. So it really just depends on the specific goal and what that study was looking at. But the duration kind of consistently throughout the literature is 30 to 60 minutes. And then again, bone mineral density, we're thinking early, longer intervention, and the more frequent that we can do it. All right, so as we look at the uses for supported standing devices and how are people using these at home, we talked about the different clinical practice technology, the tilt tables, standing frames, power manual wheelchair users, thinking about that clinical reasoning as a PT or OT, why are we using this at the timing that we are using this so we can help achieve those goals? We're looking at all the different things that that therapists do for goals in a supported standing: function, balance, strength, the weight bearing benefits, exercising, stretching, all of those different discussions that we just had. But in early SCI, we're thinking about the medical complexity and making sure that we are monitoring for blood pressure changes. We often use binders and compression on the lower extremities in the beginning until that person, regulates out a little bit better. We're thinking about the autonomic dysfunction and how we're going to manage that, as well as if any pressure injuries may be present, how that may impact our standing program and technology. So we're assessing that on an individual basis for each person that we meet, and we're discussing with, our physician team if there are any concerns along the way. But when we get more for that home use, we're talking about what are we prescribing for individuals for home. So we're thinking the standing frames or the integrated wheelchair standing systems to be able to consider recommendations that the literature is saying and that we are looking for from goals of function, health, and wellness for that individual long term. We want to reduce the amount of rehospitalization from complications that individuals are having. So that home access, we're going to talk about access here a lot, the remainder of this talk. Access is so important to this technology because if an individual doesn't have access to it long term, we're not going to see these benefits that could be obtained. Again, the home program supported standing benefits would be those medical things that we talked about, functional improvements, ability to participate in various ADLs or IADLs, work opportunities of standing, school, if they are a student, being able to stand in a school setting, leisure activities, and then again, that tool for exercise and stretching that we often prescribe for home exercise programs. Why not kind of multi-attack a home exercise program from, if we talk about resistance training and aerobic training and stretching, we can do all of that and stand at the same time and provide lots of different benefits in one kind of intervention. All right, so let's look at fitting that individual with a spinal cord injury for a standing frame. So we are going to talk here out, not product specific, but about really standing frames moving forward. So there are some key measurements that are really important that we are looking at when we're talking about fitting a standing frame. So that could be the first time that person gets into the standing frame to make sure it fits them appropriately, or it could be when we are starting to talk about prescribing that technology for home. So some of the key measurements that we want to look at are the upper leg measurement. So the distance between the back of the buttocks to the back of the knee and how long is really thinking about almost that femur length plus the tissue of the tushy. And then the lower leg distance. So that's the distance from the foot to right behind the knee. And what are those measurements? Because that's going to help us to align when we stand to make sure that the joints are appropriately aligned and not kind of, out of position for prolonged periods of standing time. The other thing that's going to also be very important is what is that client's height and weight, because different devices are going to have different weight capacities. When we think of height, there's a little bit of wiggle room to the height because we all know that somebody who's 6 foot may have very different leg measurements across all individuals who are 6 foot. So it's not always the height, it's more focused on the leg measurements. But we do want to consider what the recommendations of the manufacturer of the specific product that you're looking at guidelines are. Some other just important measurements to consider. We do want to think about the hip width and making sure that that matches the technology that we are utilizing. Some trunk measurements to decide perhaps like if we need external like chest straps or trunk chest vests, things that may help with a postural standpoint. What are the measurements of that individual? If the individual needs a headrest on a supported standing device, having that from the seat to the top of the head, so we know kind of measurements for that. Seat to the top of the shoulder to determine backrest kind of placement, and then chest width, again, making sure that we are just fitting within our device itself. All right, so some of the different considerations specific to spinal cord injury that we're really thinking when we're starting to design out and fit our frame for that individual. We are thinking about, first off, what is the client's type of injury and what is their level of injury? Because that's going to make a difference in some of the external supports that are needed in the design of that frame. So obviously, the higher the level of injury, the more severe impacts, impairments we have from a strength and sensation perspective may require more intervention on the standing frame itself. The next thing we're going to think about is how does that client transfer in and out of the device? So does the client use a mechanical lift? And we'll look at some of the variations on the next slide that we can do on a standing frame to accommodate that. We may need to have it where the backrest can be removed or where the front end of the device, the post can swing away. So that mechanical lift for our higher level of injuries or our less functional individuals can still transfer into that device and utilize it versus somebody who does like a slide board transfer or a sit pivot transfer, in which case we can maybe design that front and the post a little different because that individual can independently get in and out of the device. We're looking at what motor and strength is still present because that again will affect some of the supports maybe that are needed. And then we're looking at how much spasticity is present for that individual, especially as they change position or are in different positions, doing various activities. We may need more straps and supports for individuals who have a significant amount of spasticity to make sure from an anatomical alignment, we're not having massive spasms that throw us out of alignment and then we're standing for long periods in a poor posture. So spasticity is definitely a consideration for the different types of supports that are needed. If the individual does have contractures present, how are we going to accommodate for that in the supported standing device? And remember, there's a difference between that contracture, which is fixed and we're accommodating for, versus somebody who maybe is just early in their like evolution of tightness in a muscle and we are trying to intervene so we don't become a full contracture. So two different concepts, but how can we accommodate for that? And the most common places we see it in spinal cord injury is through the plantar flexors. We see it through the hip flexors and we see it through the hamstrings for anyone that is sitting more often than they used to. For autonomic dysfunction, that change of position and how they can access that themselves independently is important in case they have orthostatic hypotension events. And then looking at the skin integrity, does the individual already have current skin breakdown that we need to be very conscientious and aware of? Or are we at a very high risk, as many individuals with spinal cord injury are? And how do we design that? Because we can start to look at maybe air cell technology that we'll look at on the next slide that can be placed in like the posterior region of the seat as well as at the knee blocks. The client's balance and trunk, because that will determine lots of things about how the front, the posterior and anterior aspects of the frame are designed so that person is able to use the device safely. And then lastly, what are the client's goals for this? What are they going to be doing in their supported standing program? So that way we can make sure that the design of the frame maximizes that capabilities for their goals. So the different options that we talked about a bit are the front end of the frame being able to be a single column that is a post that's intact, or is it something that we're swinging away to be able to access with that mechanical lift? We're looking at options for like shadow trays, where the tray itself is in front of the individual from a seated all the way through the transition into a standing position. But there are different designs where the tray is posted in static and the individual transfers up to that tray. Depends on the person's balance and trunk control. We're looking at the contoured needs of the backrest based on how much control we have, the size and the shape of the chest pad that is available for anterior support for balance. Is that individual able to maintain that standing position without upper extremity support? Or do we really need to balance on the tray or the armrests or the different things to maintain upright posture? Because that may affect some of the other external supports that we put on that device. The seat support, we discussed that there is air cell or ROHO technology that can go into the seat now if skin is a concern, as well as at the knee blocks where that prolonged pressure may be occurring in a standing position to protect the skin. And then the foot plate, angle adjustable, being able to accommodate for range of motion or lacking range of motion in different areas where we see that kind of plantar flexion accommodation needs for individuals that are tight through that area. And then the various different types, we have chest straps, chest vests, we have pelvic straps and foot straps that can help us to maintain the alignment that we're looking at. The seat elevator, the the handle that allows us to independently transition to and from seated to standing position comes in different left and right options. So what is that person's function from a strength perception? I meet lots of individuals who are right-handed before their injury, but they are more strength on our left upper extremity from the way the injury occurred tetraplegia wise. So we may need to put that on the left side to be able to manage, or, whatever that specific individual's needs are. And then there are mobile frame options where we have the ability to move around in the device once we are in that standing position. So these are things that we're going to talk about the team that is needed to help prescribe these for home. But these are all just the different considerations we're kind of thinking in our mind as PTs, OTs when prescribing this technology. All right, and my favorite part, everybody's favorite part, right? How do we get funding and access? We know all these benefits we've just discussed. Our clients are wanting this as a goal for, that specific person who's seeking out a home unit. So how do we gain funding and access for individuals to get supported standing devices, either for their personal use at home, or some people prefer to have them like in their office environment, whatever that looks like for that person. The funding is always the most challenging part of the conversation. So we're going to dig into this, and we're not going to necessarily have straightforward answers, but hopefully giving you some of the resources and guidance to be able to pursue when that is a goal for that client. All right, so supported standing devices are considered durable medical equipment. So they fall under that DME category, and they are categorized as complex rehab technology because individuals who are not familiar, CRT has to be individually assessed for individuals with neurologic conditions is what I see in my clinical practice, but it is not something that is off the shelf that can just be ordered. It has to be assessed and fitted for that individual. So there are multiple different types of standing device codes that supported standing products are billed under. So these are called healthcare product coding systems. And they're not necessarily, I'm not going to say that every clinician needs to know all these, but when it comes from a billing perspective, the person's insurance policy and whether these different items, these codes are covered or not, will impact obviously the funding opportunities for that person. So you can see some of these different numbers here that are associated with the various styles of supported standing devices that are available. So the EO637 is that sit to stand system that we traditionally probably think of most often in spinal cord injury, where we start in a seated position and go into a standing position. It can be pediatric or adult. It can be with or without wheels. But that is kind of that standard device that I think we most often think of for SCI specific individuals. When we get to some of the other codes, the 638, the 641, we see some of these a lot in the more pediatric diagnoses where it's, the 641 is a three-way stander where we're going like prone to supine to standing, not as commonly seen in spinal cord injury. There's also the mobile frame, the 642, as well as the integrated standing into the wheelchair. So the manual wheelchair accessory and the power wheelchair accessory. So again, each device should be individualized to optimize outcomes of that person based on what their goals are and the CRT needs of that individual. But it's also really helpful to have an interdisciplinary approach to the supported standing. So it tends to be looked at, whoever the person is that's helping prescribe, whether it's a PT or an OT, but really having that whole big picture from the entire healthcare team is helpful because each person brings unique vision. OTs are maybe looking at standing in a different way than PTs and a recreational therapist. So having that entire interdisciplinary approach to how that supported standing device will be used can be very beneficial to help strengthen that justification. All right, so access, again, is that key word that we're going to talk about. So when we think of access, how do we gain access to the equipment that we are trying to get that individual? There are several resources, and this is not an all-inclusive list, but there are several resources for kind of what are the best practice guidelines on how to obtain complex rehab technology. So the Resna Wheelchair Provision Guide, which we'll look at in a moment in a little bit more detail, is an excellent tool for individuals who maybe don't have as much experience in a structured seating clinic on what are the steps that are needed to procure, obviously it says wheelchair, but CRT in general. The Clinician Task Force, which is an organization made up of clinicians across the country, they have multiple resources for clinical practice on best practices on how the seating and wheeled mobility services processes work. And then the World Health Organization also has wheelchair guidelines, training, and wheelchair provision standards. So that way, again, our industry is trying to structure and standardize how individuals can access the technology that has such a big impact on their life. And we know if you work in any neurologic population, but in spinal cord injury, it's a big barrier the amount of time that it takes to go through this process for an individual to get things that are necessary for their everyday life. So the Resna Wheelchair Provision Guide kind of steps that are recommended for best practice are the referral needs to be made for an individual for we're going to talk about support standing because that's what this discussion is. A referral needs to be made for supported standing device. We need to identify that person needs this. Qualified professionals, so a physician or a nurse practitioner somewhere in that practice refers that individual to a PT or OT for assessment. We go through the assessment process where we look at all of the different functional capacities of that person and strength, and we do our formal assessment of what are the needs of that individual. We go through the equipment recommendation and selection process. And this is where the supplier comes in. And we'll look at the role of each individual, but trialing different products, exploring what the funding options are, documentation, the letter of medical necessity, and all of these different things. And if you notice, funding is actually not the first thing on the list. So it is important that as an ATP, we learn that we are not just providing education about technology to individuals based on their funding abilities. If it is appropriate, we are educating the client that this is available for something that can impact your life, and then we pursue the funding opportunities. But it is not the sole reason that we never introduce it only to people who have insurance or something along those lines. It's really important that we understand that as a healthcare team. So the CRT team that is involved with this process of the funding is going to be the client themselves, the PT or OT and the medical provider, the physician or nurse practitioner DO, the rehab technology supplier, as well as the funding source themselves. So as we go through each person's role, because it can be a little tricky and overlapping sometimes, the client's role is that they have to choose the complex rehab technology supplier they're going to work with. They've got to discuss their goals and needs. They're going to be an active participant in the trialing process and show willingness to use that device. We're going to appeal if it's necessary for that person if they get denied from a funding perspective. But the client plays a key role, obviously, throughout this process. The therapist's role is really to determine the medical clearance, initiate the standing program, the recommendations for it, determine the appropriate device with the combination of the client and the supplier, and then make sure that we're setting goals and monitoring that program, and then writing the letter of medical necessity that is needed to be able to obtain access and funding for that device for home. So this is all combined with the team. For the rehab technology supplier, they're really assisting with the equipment device for the trial. So they're providing that if needed. They're giving their expertise to the client and the team on the available technology that is maybe appropriate for that person. They're working on like the prior authorization paperwork from the funding source, and then assisting with any of the denial processes that we see in complex rehab technology. They're also going to assemble, deliver, and fit the device to the client. And for supported standing devices, this is most often done at home because you can't transport that to clinic in multiple different places. So a lot of times it is the supplier, the ATP, that's doing that in the home environment. So what type of funding is being utilized for access to these supported standing devices? So there are national programs, so things like Medicare, Medicaid. Now, we know right now that Medicare, straight Medicare, does not consider supported standing as a covered item, but some of the Medicare the MCOs, it may be something that is considered. So we need to look at that on an individual basis. Each Medicaid, although it is a federal program, each state's Medicaid program is different. So you really have to know the terminology and wording of your specific location to understand what that coverage is from a Medicaid perspective. And then we also have commercial insurances that oftentimes will follow kind of the regulations of the federal, the Medicares and things like that. But each commercial insurance, again, has their own terminology. So each plan has to be assessed. We can't just take these kind of generic, like everybody falls in this category. It has to be investigated by the client and determined, in the CRT team. So we have to understand the specifics of the insurance guidelines for that particular person. And the words, unfortunately, are very important. When we get into the letter of medical necessity, there are many tools now that are available that we'll go through briefly to discuss the different components of the LMN. But some of the key things that we have to include in this letter of medical necessity to be considered for funding, we need to put our own credentials as the clinician, the client's name, date of birth, their height and weight. I accidentally left a height and weight off once, and the whole thing got denied solely on that, and I had to quickly resubmit. Height and weight is important. What are the goals of that supported standing device? The history of the client, their diagnosis specific to their needs for the supported standing device that we're going for, the onset of their injury, their prognosis, and how that device will be used over time, as well as any comorbidities that may be relevant to the goals that you have for that CRT. Their physical exam, their functional assessment, all of these things need to be put into writing for the funding source. And then we need to document why the standing program is recommended and appropriate. So if there is any literature that you can include, that only strengthens that letter of medical necessity. You need to discuss what your specific recommendations are. Why, what is the frequency and dosing and how that device you're recommending is going to be used by that individual. You need to discuss what other devices maybe were considered and ruled out and why the one that we have selected is the most appropriate for that person. You need to put in the actual trial. This client trialed this standing product for this long, and these were the outcomes, and there were no adverse effects, to make sure that the funding source knows that that technology can be used safely. We need to justify each of the components that we add on to the supported standing device for all of the different various reasons we discussed. It's also really important to state that the client or the caregiver, if needed, the client specifically demonstrates the ability and the willingness to use the device safely. So that's really important to put into the letter, because I've seen some kickback in some various ways when that discussion hasn't been had. And then again, anything you can do to emphasize the statement of what are the consequences of not participating in a supported standing program and what are the effects for that individual, will again strengthen that letter of medical necessity. So there's a few other documentation needs in addition to the LMN. We do need a prescription from the client's physician for that device or the supported standing. Any medical team members that were a part of the evaluation need to co-sign that LMN. So sometimes it maybe is a PT and an OT or just one or the other. If you have psychologists that maybe can talk to some of the mental health pieces, I've seen many different things over years, but the medical team that was involved in the prescription needs to sign. There needs to be some documentation that the client's home environment can accommodate the device, the supported standing device that you are recommending. And then there needs to be some kind of detailed order form and quote that is also submitted, and that's usually done by the supplier. Now, here at Ultimate Medical, there is a tool, if you go to our website, called Justify It, and you will register. And this is a tool that helps to generate a letter of medical necessity for products like EasyStand, Zing, or Activate. So it is specific to those. And then it helps you to just kind of simplify the process. So this is a tool, it's free, that you can go in and register and start to plug in the information to help kind of give you this LMN document, especially for individuals who aren't very comfortable with the LMN process or don't do this on a regular basis, or just looking for a way to standardize their LMN writing. So when you go to the website, you'll see the different products. You will choose that specific one. So let's just say Easy Stand for this instance. And then it will give you many different boxes that you will fill out. And again, HIPAA is respected in this documentation program, but it gives you different options of what you are selecting, and then it helps you plug in the various aspects of that element that we just discussed. So summary of the medical condition, their prognosis, and it gives some nice little tips and cues for things that can help strengthen your specific justification for that. So this is just a snapshot of one aspect. The document itself is much longer, but it's a really nice tool for individuals to help with that LMN process. So lastly, we're just going to end with knowing that you don't get into spinal cord injury rehab if you are not willing to advocate, because so much of what we do across all of spinal cord injury rehab, across all of complex rehab technology, and across supported standing devices is we are advocates for our clients. And there are a lot of resources available to us to help with that advocacy journey. So just reminding you, this is not a comprehensive list at all. There are probably many more organizations than this, but these are some of the more common ones. That it's important that if you are finding challenges with getting, we're going to say supported standing frames because that's what we discussed today, but any complex rehab technology, get involved, advocate to make changes across this system that we are all a part of for our healthcare environment, to help make changes to improve access to technology that our individuals that we serve need. It's also really important to encourage the individuals that we are working with, the clients with spinal cord injury. Get involved in advocacy, raise your voice, be able to say out loud, no, this is unacceptable that these things are being denied, and find the right resources for that individual to make an impact. So some of the advocacy resources, again, not a comprehensive list, but RESNA, INARTS, NCART, the Clinician Task Force, the ITEM Coalition, United Spinal Association. There are a lot of different ways that we can give resources to help us as clinicians, but also help our clients to have a voice in this process. So, lastly, as we end this discussion today, I also do want to remind you that if it is specific products for Ultimate Medical, like Easy Stand, that you can always at any point reach out. We have a team that can help with some of the funding discussions, as well as myself and then Marianne Girardi, who is our other clinical education specialist and is brilliant and has worked in the funding world for many years of her career. We are always happy to provide feedback or suggestions for LMNs that you may be working on and having trouble with, or denials that you have been impacted for your client. You can always reach out, and we will try to, can't promise any guarantees, but we can help provide just a second pair of eyes and insight to that. So we are going to go ahead and open this discussion. These are the references, just so you can see them. We're going to open this discussion up for questions. Thanks so much.
All right. Kristen, it looks like you've got quite a few
Oh, I don't
questions.
have my chat up. Let me look.
In the chat, it looks like there's a bunch of questions and comments as well as one in the Q&A.
Okay, let me see if
Um,
I see 29.
But as people are kind of, as we're commenting our questions, I'm just going to go over our housekeeping at the end here. I
Yes.
just want to say thank you everyone for joining us today. I really hope you enjoyed the presentation and the content that was presented today. Like I said, there's a link to the slides in this chat, and then it's also available on ultimatemedical.com/education. You can find our slides there as well. To obtain your CEU after this course, you must complete the survey that will show up automatically in your browser after you exit the webinar. If it doesn't automatically populate, don't worry, that link will be available to you in a follow-up email you'll receive in approximately 24 hours. If you don't receive that follow-up email, please check your spam folder. If you still don't receive that email, please send us an email at education@ultimatemedical.com, and we will help you move forward that way. But once you complete that survey, your response will be verified by our education team. A certificate of completion will be emailed to the email address you used to register for this Zoom webinar. Please keep in mind that this will take a few business days as we do all of that manually. And like I said, this course will be available on demand soon, along with the rest of our uh, along with the entire catalog of on-demand CEU accredited courses. Our courses are accredited for both PTs, OTs, and ATPs. So I guess not both, but um, if you or someone you know would like some more free CEUs available on your own time, be sure to check those out again at ultimatemedical.com/education. That's ALTIMATE medical. Again,
Okay.
thank you for your time and attendance, and I hope you enjoyed it. If you have any questions, please shoot us an email, and I'll turn it back over to Kristen to answer some questions.
Okay, so I'm gonna try to work through these, and if you are able to stay, please hang out. And Marianne, who is also one of our team members, you're welcome to kind of join in on any of these conversations. Let me know if I miss any of these. So in my practice, I have reasons for both wearing any orthotics and not wearing them. I'm curious about your thoughts when using a passive standing device. So I would say I've seen and done both. So if that orthotic is necessary for joint alignment and protection, then it can be beneficial to utilize, obviously, that in a supported standing program. But I am considerate of where that device is contacting. So if it's something around the knee area, how is that contacting and putting pressure, especially in SCI where we are so concerned about skin health? So I really look at it on a individual basis, person by person, as to why is that needed. So unfortunately, there's not a straightforward answer to that, but why am I using it? And what are the risks of where that may contact the technology that I'm specifically using? All right. Differentiate supported standing frames systems and sit to stand transfer systems. I've had therapists not understand the difference. So kind of looking at why the technology and what is its application. So there are some devices that can kind of help you to get into that like partial stance for transfers. I didn't use them that often clinically in practice, but they do exist for I'm saying for spinal cord injury specific, but there are devices that are meant for transfers and there are devices that are designed for prolonged standing. So understanding what the manufacturer's kind of considerations and recommendations are for how that device is used is very important. And that's where your CRT team can help you. So if you are unfamiliar with the different technology that's available, reaching out to your supplier to be able to give you different options of what technology would best meet based on the goals that you have and what that looks like. Um, me. Okay, sorry. As a wheelchair technician who aspires to. Okay. Curtis, maybe you and I can talk one-on-one about that. Can the standards be? So, can standards be rented for clients who are not sure they can afford the device or even justify for funding source that clients has benefited from use after renting a month or two? So, I do not know of any rental programs that are available, but what I have seen and actually helped to develop in different aspects for wellness in the community that I'm a part of are wellness programs. So if there is not access to whatever reason, personal use devices, finding ways that maybe you could incorporate a wellness program where individuals can come in and utilize different devices is another way that you can kind of see that individual can trial something outside of clinical practice. But I personally don't know of any rental programs. I can't say they don't, maybe I can't say all options that are available, but it's not a standard way of doing this. Okay, sorry, my vendor. Oh, there, sorry, there was an answer below it. Okay. Here is one that says, I am an inpatient PT, and in the past, I received word from vendors that a standing frame was denied for a patient, but this patient is long gone from inpatient status. It has fallen on me to pursue appeals, but I really do not have time for that when I carry a full inpatient load. What do you recommend regarding roles to best serve these clients? So it does get very, very tricky in our current healthcare environment when we are prescribing early and then maybe losing that person out of our specific plan of care. So as the individual who did write the letter of medical necessity, yes, we do go through the appeals process, and I have done it many times. I was an inpatient therapist for my whole career, so I have been through this process as well. it's not, you're not having to rewrite a full letter of medical necessity. So you are going in and kind of identifying what area do you need to strengthen your justification, and then submitting that paperwork. And then sometimes it's even pursuing via, if it goes as far as like phone calls, the physicians can also be involved in this process, but phone calls if it's going, further down that appeal process. But if you have a continuum of care, that an entire seating clinic continuum of care can assist with this. But otherwise, yes, once we start the process, it really is our responsibility to help throughout if our clients want to appeal or we want to appeal that for our clients. These standards are usually, sorry, I'm checking to see what's questions and what are people commenting towards each other. Yes, so it looks like the standards are there only for one person, personal use, or is there a company? Yes, so in clinics, you will often have a demo product. So you can reach out to the suppliers in your area or contact Ultimate Medical and we can get you the right person. But demos can be used in the clinic where you may trial it with multiple people at once before you pursue that in home or that personal device for that individual. So yes, you can do both. Personal devices are when that individual owns that versus one in a clinic or wellness program that multiple individuals are using and we're changing the fit along the way. Okay, sorry. Ron Conrad, Marianne, I may direct that question to you. What can you do when using a standard for a CP diagnosis person who has a windswept posture?
It's tough. I have had success getting, I'm assuming, Ron, you're talking an adult CP. I've used both adults and pediatrics, and with the windswept, you sometimes need to put a little extra support on the externally rotated leg. Luckily, especially with our standards, you are able to rotate the foot plates to meet the needs. Unfortunately, it is a very individual process. I've had some success using the padded pelvic strap and actually using it to control the external rotation just above the knee, but it's individual. If you want, Ron, you can either email me or call me and we can work it together. If you call Easy Stands or Ultimate Medical's main line, just ask for Marianne Girardi and they'll send you to my phone. Sorry.
Thank you, Marianne. Marianne she has many years of experience with CP. Okay, I think that is the majority of the questions. At the bottom here, and also if you go to the Ultimate website, you can see Marianne and my information listed there. So please feel free to contact us. I'm going to put in the chat my email as well. And Curtis, you specifically are welcome to email me and we can chat more. We can set a phone call. But I think that is everything. So I really, really appreciate you guys joining us today and look forward to working with you all in the future.
Yes, thank you everyone for joining us. Like I said, that survey will automatically populate when you click leave webinar.
All right.
There was a question, Kristen,
I
about
do see a couple more that a few more that have popped up.
for using it for reference. In about a week or two, this webinar will be on demand for free on our website, and you can watch it as many times as you'd like.
Looks like there's one in the Q&A
I
as
do
well.
see that one. Yes. Okay. So sorry, one more. Is there any data or research that compares supported standing in a standing frame versus the standing features available on a power chair? And are they both equally effective? So the studies often kind of clump a lot of different technologies together. There are some that do individual ones, but yes, I would say supported standing through various technologies. Obviously, each individual person is going to have reasons for why one may be prescribed versus another. So, yes, they are both supported standing technologies that kind of fall into the different evidence categories that we discussed today. So, it's really looking at that on an individual person's needs and bases and preferences as to why you would choose one versus another. Okay, I think that's all of them.